right away. So I think it is showing. Dr. Raghu, please do monitor the FB page if there are any uh, mm, comments on that section.
Yes, sir.
Yes, I think the meeting is now live on FB exactly on the time that we wanted, 7:05 or 7:10. It's exactly 7:10, and we are not late as informed. So what I was mentioning was, yes, on record on the national screen or the national television, yes, Idea Thiruvallur is one of the best organized branches. So credit goes to the whole team, especially the president, the secretary, and the CD convener, and of course the whole team. So let me just share my screen first, and just please let me know whether my screen is visible and am I clearly audible.
Yes, yes,
Yes,
sir.
sir. Yes, sir.
Okay, great, great. So three of you are co-hosts, so kindly keep on admitting wheresoever you feel the audience is entering from your branch, since the link is in your branch only. So audience watching on Facebook can post their questions on the FB page, and participants who are joined in the Zoom meeting, please do keep posting your questions in the chat box, or at any point of time you feel any query, just keep posting in the chat box. I'll take up all the queries in the end once my lecture ends, in the sequence from the chat and then from any questions from the live audience. So don't bother about 7 to 9 p.m. I'm here till 10, 11, whatever time you want me to be, if any queries are there, because I always know there are a lot of queries in any kind of medical legal session. So sometimes the session is 2 hours and the queries are 2.5 hours or 3 hours. It has happened many times in the recent past, so I'm pretty much aware of it. So the session, my presentation would take roughly close to 90 minutes or so. So I hope to finish by 8:40, 8:45. So let's begin without much delay. So all my presentations always begin with thanking the Lord Almighty, who's given me much more than what I deserve. Uh, Usually my medical, legal, and finance presentations begin right away after this slide. But my finance presentations have one extra slide, which I've added for, although it is a medical legal one, but I've added this slide over here. Since it is a Father's Day, and I was very attached to my father. It was 2 Junes back in 2019, on 30th June, that we lost him. But yes, even if it is not a finance presentation, my big thanks is due to my dad, who actually was instrumental in shaping me and my career in the way I actually am currently over there. So this is my brief CV. Dr. Raghu has already told you about it, so I won't be wasting much time over here. So this is the topic for which we are here, Idea Thiruvallur branch, 5th CD program 2021. The topic is importance of customized consent form in dentistry. Uh, so this is the abstract. Dr. Raghu already told you. So big gratitude once again to one of the most organized idea branches in the country. So all the team, the immediate past president, Dr. Siva Sankri, the president, Dr. Rajasekharan, president-elect, Dr. K.C. Bharati, Dr. Nagarajan, honorary secretary, Dr. Sarojini, honorary treasurer, Dr. Raghu CD convener, and all the members of scientific committee, Dr. Sukanya, Deepak, Dr. Santosh, and Dr. Prem Karthik. So thank you so much for inviting me here. And of course, big thanks to the guest of honor, Dr. Uma Shankar as well, who is the president-elect Tamil Nadu State Branch for the next year. So let's begin, because why we say customized consent form, or why we say just the consent form itself, because the same stems from the principles of medical, legal, and ethics. For whatever reason, they are adaptable or applicable to our society. It is all about the moral concepts and the moral principles and theories which we actually do. So ethics basically tells us that we ought to act within those valid principles which are applicable to us. And if we define ethics in a simple line, it says a code of conduct or morals advocated by a particular individual, society, or a group. So if you want to derive what exactly is morality and ethics, both of them derive their meaning from the Latin and Greek word, and the meaning is the same: the custom, the traditions. So Aristotle, the great researcher, the philosopher, called ethics as a study of character traits in sense of virtues and vices, the good and the bad. So why are we discussing ethics when we have to discuss the consent part? So because ethics is the foundation of each and human, say the ideal human character, how we ought to behave in a certain situation, in certain circumstances, and how we ought to respect our morals and principles, or the medical ethics principles which are applicable to us. And in that, we sometimes encounter a situation where we have a scenario that we should be able to make a distinction that what is right and what is wrong, and what is best for the patient, and duty must be followed at each and every cost, and obviously good interpersonal relationships should be maintained. Over the period of years, over the last decade and a half, mostly in the past 15 years, I would say, there has been a lot of dramatic shift in the decision making in the dental clinic. There was a time when the patient said, yes, doctor, you are equivalent to God, and you do what is best for me. Then it came down to the patient choosing the treatment themselves. Of course, and now it is or sorry, they both made the decision themselves, called as a shared decision making. And now it is the time to actually respect the informed and the autonomous decision of the patient. The concept of consent stems from here itself, the autonomous decision making by the patient. So we have come a long way since the Consumer Protection Act, and doctors are no longer equivalent to God in that sense. Because if the God can be dragged into a court, then he's no longer a God, of course. Yes, it happened in one of the Hindi movies, Oh My God, as well, and God was also dragged into the court. But then a fiction and a reality is something different. So how unfortunate we are that we actually want that every one of us should be following the same ethics and the same principles. The unfortunate reason that we give is that if I am not following ethics, is my fellow dentist, is my bajuwala dentist, is my neighboring dentist following the same? And ethics has to be like a uniform code, and we want that everyone should be wearing the same uniform. But unfortunately, that does not happen. The biggest reason, the biggest ethical challenge for us is that people actually don't know, and they always say ignorance is not a bliss. So if you don't have a knowledge in ethics, it does not mean that it does not exist. It surely exists. So these are the key principles of medical legal ethics, and one of that principles actually goes on to the consent. So starting with the first one, the beneficence. The beneficence principle means doing only good for the patient. Non-maleficence means doing no harm to the patient. Justice means treating all the patients with equality, irrespective of any discrimination based on caste, creed, and religion. Then veracity means truth telling. And lastly, the principle of autonomy. Of course, there are other two micro principles as well, but the patient autonomy means respecting the patient choice. If the patient has a missing tooth, you give all the options from starting with the implants. Of course, I'm taking the feasibility into consideration, that yes, all the principles, all the say options of missing tooth are applicable, the bone parameters, all the parameters are correct. So starting with the implant, you go up to the RPD, and the patient can afford the implant easily, but then the patient chooses an RPD. It is your duty to make the patient realize what are the pitfalls of the RPD, but you have to respect the patient autonomy in that case, even if the patient wants to go with that option selected. Yes, it should be very crystal clear that whatever it is not exactly an RPD, we call it a gum stripper also sometimes, what harmful effects it is going to give. So you should be very much clear about it, and tell the patients of not getting it done or getting it done, and the side effects of all the options. That is what the patient autonomy is, and that is what the basis of the consent is. So these are a few principles. As I said, another micro principle which was not mentioned over here is the principle of confidentiality or fidelity. So this principle means that whatever happens between you and the patient, in terms of documentation, in terms of treatment planning, that all needs to be kept confidential. You cannot share the patient information by the law. Every day we see a lot of cases being shared on the social media, and I sometimes want to ask the fellow colleagues, dear colleagues, have you taken the consent from the patient to share their pictures? If not, kindly do not share them on social media. Even if the patient has given the consent, I always advise the patient's eyes to be blinded so that the identity is not disclosed. There is no harm, there is no problem in sharing the intraoral pictures or intraoral x-rays. Obviously the x-rays would be intraoral only, or the x-rays, because those, unless the name is written, they will never disclose the patient identity. But showing the patient faces, the before and the after, that needs a, even that needs a written consent from the patient. And even if the patient says share my you can share my image and gives it in written, as a precaution, I always advise the patient still to be blind over there. So the rest of the principles remain the same as I told. So the principle of autonomy is what we are basically concerned about, but I'll be discussing a little bit about each principle just in a slide or so. So autonomy means the patient has the full right to information and then self-determine what is the best for the patient. So the patient has full right to free and informed consent, free will and accord, and obviously the intentional participation in the treatment. The respect and dignity should be maintained, but as it is mandatory, the patient should have the capacity to think, decide, and take action. That means the patient is not in an inebriated state, either drunk or under the influence of alcohol or drugs, uh, or the patient is not mentally normal, or the patient is not able to make sound judgment. It should not, this should not be any such case with the patient. So then I told about the non-maleficence principle. It means doing no harm to the patient. Sanctity of life, in our case, sanctity of tooth, has to be maintained. Risks and benefits and options have to be weighed very, very carefully. So beneficence means doing only good for the patient, always acting in the best interest of the patient, considering patient's welfare as paramount, and always weighing the chances of success against the risk of the treatment, and always mentioning the same, always key. If you're going in for a treatment, if you're going in for a, say, uh, root canal in a case where the furcation is about to be involved, always warn the patient of a, say, a vertical fracture, which is a very likely possibility. Yes, your intention is to save the tooth of the patient, but that should be weighed against the risk of the tooth being fractured. So always learn to say a no where you feel that the risks outweigh or outnumber the chances of success. Always keep those things into mind. The main consent part is always concerned with the three words, the RBOs: the risks, benefits, and the options. So again, justice principle says no discrimination made on any basis: caste, creed, religion, sex, color, race, position, rank, whatever you can think of, any other than that as well. So the patient confidentiality, I already mentioned, you should not be breaching that, or this should be done only if ordered by a court of law, and or if there is any public requirement, and or in case of any malpractice suit, or if you want to share with a colleague, obviously you can share, ask for an help, but without disclosing the patient identity. Obviously your colleague will never be interested in the knowing the patient identity. We always can do that without disclosing the identity as well. So confidentiality is based on the principle of loyalty and trust also. So we should not be revealing that unless or until it is ethically and legally required. And even in those cases, the disclosures should not be beyond what it is required. So confidentiality is the key. So the percentage of patients who actually would say that honesty is still the best policy is still high. And it is our custom, culture, and traditions which actually helps us to decide that yes, the culture is still to follow the honesty, which is still the best policy. And obviously, the patient has the full right to honest and a full disclosure. If you break a file, you need to tell the patient. You need to tell the patient very, very clearly. And obviously, if you have taken the consent, you have already warned about the file separation or the file breakage, we call it as the file separation these days. You already mentioned that as a side effect of or a physical outgrow of the treatment, or it is not exactly a negligence. If that way, there are two facets to it. You inform the patient prior, get the signature done on the consent part, mentioning that again instrument separation is a part of a procedure which can happen, not as a mistake but sometimes as a part of the procedure. You can't sometimes know how fatigued the file is. So if that happens, the only thing is, if that happens at in the stage of the treatment, the due course of treatment. You have to inform the patient. The principle of veracity comes in, and at that position, you have to give the first aid to the patient in the form of a specialist. The specialist should come and treat the case, or you refer the patient to the specialist who should get the instrument removal or the bypass done, whichever feasible and possible. So if there are two again parameters, if the specialist is successful or not. If he is successful, then again you can proceed ahead with the normal root canal. But if he is unsuccessful, then the choice again falls back to the patient, whether he wants to continue with such a tooth with the file separation in, or whether you want to get the tooth extracted, the file onto those cases. So in those cases, let's go back. The file is separated and you call a specialist, or you refer the patient to the specialist. What about the cost part involved? So the cost part, obviously, you can charge the patient, but as a personal protocol, I always advise don't charge the patient for such a mishap, since it is your mistake or a part of procedure also. But those things should be very, very specifically told to the patient beforehand. Now, when this particular facet becomes negligence, is that you don't take a consent, you don't inform the patient prior about such procedure, and then the file breaks. And then you even then don't inform the patient, seal the root canal as it is, and the patient goes away, has a pain, maybe a year and a half later he has pain, goes to another dentist only to find that you had broken the file. In those cases, this thing becomes a negligence. The same sequence of events, the only thing missing is the consent and the principle of veracity. So remember, if you are doing that, you are still following the medical legal laws and the ethics standards, and you are not liable to be punished. But if you are escaping from that, you are surely about to be fall into the trap of negligence, which is not a good trap to have. So then the word exactly is not consent, it is the informed consent. The only thing is that the patient should have an adequate disclosure about the nature of the procedure or the intervention, the risks, benefits, and the options. The three words that I mentioned, I'll keep using them again and again through the presentation. Risks, benefit, and options should be weighed against all kinds of treatments. So what constitutes an informed consent? Disclosure. Yes, obviously the patient should be able to make a correct decision, understanding of the information that has been given. Do not use scientific or the technical jargon, always use the simplified terms. Then voluntary, it should not be forced upon the patient to sign against. Always weigh the chances of success and failure against the risks of any problems been happening. And then agreement, verbal or written, to discussed intervention, whatever you have discussed. So our relationship with the patient is actually based on a covenant of truth and a trust between the doctor and society, and of course between the patient. We are supposed to be a professional and a healer, and we have to offer our expertise to the patients. And as a veterinary doctor is expected to love animals, physician needs to love for the health or the humanity, the dentist should have love for the teeth. That is the conclusion of this part of the presentation. So if I hope I am not boring you enough. So let's begin with the main topic after the introduction about the same, the consent in dentistry. So consent literally means just ask. So the word also means the patient agrees to your treatment. I agree to your treatment. So yes, part of the presentation. Okay, so word exactly is not the consent, it is actually informed consent. So where does the concept of consent come from? So if I had started my slide from this, you would feel confused. What exactly is autonomy? So that is the reason I laid out the micro principles of ethics beforehand, so that you understand that what exactly is going to be dished out in the coming slides. So the consent, it is actually a patient's respect for his opinion, his decision making, his own self-determination, and his integrity. So the legal issue means that protects every patient not to be touched or treated without his or her authorization. That is the bottom line of consent. That is what the consent stands for actually. So it was first, the word informed consent was first introduced in therapeutic practice in 1957. So consent is not a event, one time event. It is a process that continues. And a consent is meant to give the patient the knowledge which makes him or her the equal bargaining partner. It is as simple as that. If you treat the patient yourself, you are the god phenomenon for the patient. And if something fails, the patient is biased, is say bound to point a finger at you. Doctor, I trusted you, I treated you like a god, but you have betrayed my trust. My tooth is broken, my tooth is fractured, my tooth has been lost, whatever can be the thing in such a situation. But when you do a consent signing in a proper format, in a proper way, with the patient and you making a shared decision, or maybe patient and you making a determination for the treatment, or maybe the patient choosing from the treatment from the options that you laid out in a particular sequence. So that makes the patient equal bargaining partner. That means that you alone cannot be pinpointed for the mistake or any problem that occurs because of any physiological reasons as well, and not necessarily the treatment protocols. So obviously the skill parameter still comes into account. Obviously you're following the requisite standard of care does come into account, but it does not mean that you alone would be blamed for that. That is what the beauty of this consent principle is. And we sometimes are hell bent upon taking all this thing on ourselves rather than making someone an equal partner in crime. Not of course crime, it is no pun intended in that, but what I mean to say is that an equal partner where he or she is also involved in decision making. So it is actually, we are still bound by the Indian Contract Act 1872. It is a British act, and it does mean that with the advent of CPA, Consumer Protection Act, the doctor and the patient relationship is a contractual relationship one, and it is not a god and a bhakt phenomenon anymore. So literally consent means to agree, as I told you in that slide. So it is a agreement or a permission voluntarily given without any compulsion. So as I told in Contract Act 1872, two persons agree or are said to consent if they agree upon the same thing in the same sense. What you said, the patient understood that, and then only he signed that. So obviously in a consent form, what is important is that you actually have four signatures on the consent form: you, the patient, your and two witnesses. The two witnesses can be the patient accomplice and the doctor accomplice, your assistant, your associate. Anybody can sign as a witness. So when there are when everything has been explained pretty well in a decent manner, and the patient has understood that and agreed to or given the consent for that, and he signs that, trust me, when there are four signatures on the sign on the form, the patient will think twice or thrice before going to court if he knows that he has understood and signed that. The problem is not about the consent form. We actually don't know the basic parameters only. As Dr. Raghu also mentioned in the beginning, what we get on the internet is the body of the consent form. The top and the bottom has to be customized. I'll be giving you certain examples as we go on further. So how you actually decide that what is going to be covered in the top and the bottom of that. Because if you are just mentioning the risks and the benefits, you are actually not making the full use of certain things. Now, giving you a few examples, what I believe, your treatment consultation, your discussion with the patient has to be at the top, and your clinic procedures, your clinic policies and procedures, clinic rules, and the treatment costing has to be in the bottom. The top and the bottom can be interchanged also, it does not make any difference, but what exactly is the content of that, that is what is important. For example, I'll give you an example. The patient comes to you, he says, please check into my tooth, it is hurting a lot. You check the tooth, it is about to be separated from the furcation, about to be fractured. But yes, obviously, if it is near furcation, then it is be a pulpal exposure also. So the pain is because of the pulpal exposure. You tell the patient, yes, your pulp is involved, but the tooth is about to get fractured from the furcation area. So what do you do? So the patient says, "Nahi, doctor sahab, please, 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 please save my tooth." So you take a consent for the root canal, and you have told the patient everything, and you just take the body of the consent without customizing the top and the bottom. I'm talking, and yes, the tooth and all those things can do, and everything. You even mention that yes, the tooth can fracture and all those things. You mention it very clearly as it is mentioned in the body, and get the your signature and the patient signature done. Or sometimes in worst case scenario, we talk to the patient verbally. It says, you tell the patient that yes, the tooth is not going to be saved. Doctor, please save it as much time as you want. Though maybe it will run for 2 months, 3 months, 4 months. Please save my tooth. I don't mind that. You save the tooth. Obviously, sometimes you give a direct restoration followed by crown also. Sometimes maybe the patient spends close to 7-8,000 rupees and goes away. In couple of months, the tooth fractures. The patient comes back. What have you done? The tooth just fractured. You will tell, I told you it is going to fracture. Not that soon. It should not have fractured soon. At least it should run 6 months. The patient forgets that. Now, what is the proof with you that you discussed with the patient that it might not last even 2 to 3 months? Nothing. So even if you take out, even if you taken a signature on the consent form, it will mention as a side effect, yes, the tooth can fracture from furcation. Even then, the finger will point out at you. The patient will demand an X-ray, and you have a right to give a copy of the X-ray. Especially these days when we have a digital X-rays with us, the patient has full right to the copy of the X-ray. And yes, you still can charge for that photocopy or the printout. You can do that. But then if the patient takes the pre-operative and the post-operative X-ray, you might have done a wonderful root canal. I'm not going into that. But a pre-operative X-ray suggests that this tooth is destined for extraction. What proof will you have in court to give that I told the patient that this tooth is going to last 2 months? Nothing. You will be fallible in the case of a medical negligence sometimes, of course. Again, this matter is not decided by an individual court. They refer to an independent medical or a dental board who decides that. And that board decides that yes, this tooth was not fit enough to undergo root canal. So your case selection was wrong. Your diagnosis was wrong. You shouldn't have undergone, you shouldn't have proceeded with the root canal in those cases. Whatever plea you may give, it is all verbal. Whatever, even the consent form you give, I mentioned it is a part of treatment. 2 months, sometimes that also might not be taken into consideration. So remember, the top and the bottom customization comes into play here. You mentioned the consultation part that yes, the tooth is bound to fail, but on the persistent request of the patient, we are saving the tooth. The patient is fully aware of this. Yes, the tooth can fracture in maybe a couple of months as well. The maximum life cannot be guaranteed for that tooth, whatever life it has. So we will still try to do the best. And the bottom, irrespective of the patient told, we are going ahead with the treatment, and the total costing involved is this. So even if the tooth fractures in a couple of months, the cost will not be refunded. That is your clinic rule and a policy. So the top and the bottom, just one simple example to save you. Okay. So now let's go to another scenario. Just a repeat scenario, or just the opposite scenario of this. The patient comes with a cavity which is more than class 1, you can say almost on the about verge of touching the pulp. You know it by just by feeling with a probe that yes, the pulpal exposure is there. Yes, of course, I'm not telling you to bypass the X-ray protocols. You still have to take a preoperative X-ray always in any case. So you go ahead with the X-ray, you tell the patient that this is the tooth that can be saved. The patient says, extract it, remove it. You explain the patient about the tooth being a body organ, not saving will lead to, say, supraeruption, the drifting of the adjacent teeth and whatnot. You can undergo, explain patient about all the scientific terminologies, but to no avail. The patient still says, remove the tooth. So you remove the tooth, and you take the consent for extraction. You take the consent, the body of the consent for extraction. The patient before going says, doctor, please give me the X-ray. You remove the tooth. You said you have removed the tooth. What purpose would the X-ray serve to me? RVG or a physical film, you give the same to the patient. 2 months later, you receive a notice from the court or from a lawyer. My tooth was extracted without informing me of the side effects. You took a consent for extraction in which the risks with the extraction would be mentioned. There's a tooth that bleeding can happen, swelling can happen, pain can happen, even maybe of a jaw fracture can happen. You mentioned all those things, but where did you mention the patient consultation? Even if you have taken a consent, mostly people won't be taking a consent for a simple extraction. So that is where it comes in handy. The patient's tooth can be the top and the bottom. Top, the patient's tooth can be saved very clearly with the normal procedure of a root canal followed by direct restoration or followed by a crown, whatever, according to situation you want to enter, you want to write. But the patient insists on extraction in spite of explaining the thing very, very meticulously to the patient still wants to undergo. So we are proceeding as per the patient's wish and will. Underneath, yes, extracted tooth cannot be implanted back into the socket, and our charges for the same are this, which are non-refundable. You sign along with 2 witnesses. The patient, even if he goes to the court, you have that document to save you. So 2 just very small examples. In case you have not done this top and bottom thing, you receive a notice from the court or from a lawyer about who wants to go to the court or wants to milk the money from you. What is the answer? What is the answer? It was a tooth. I was just told that this tooth has developed a fungus. This tooth has developed this ABC problem. The patients will make a lot of excuses if they were about to mint money or if they have a personal grudge to settle. Sometimes that will happen always, or rather sometimes. Sorry, not always. That can happen sometime. So remember, what is your protection? What is the protection? Only a simple consent form of extraction, where it does not specify whether that tooth was the extraction case or a root canal case. It is just verbal thing. Or even if it is a written thing, it does not mention anywhere your consultation, your discussion. So you really need to ask yourself, what are we getting into? So all this also means that you are about to be fallible when it comes to the lack of documentation. And consent thing starts from record keeping, surely. So the only thing is, the courts always say, there are a few judgments. 2007, 2008, Supreme Court made a judgment that every tooth, every patient has, irrespective of his social class and stature, that means any class 1 to class 4 patient has the right to be given all the options of a treatment. For example, if it is a missing tooth, you start from the implant part. Has every patient, irrespective of his class and culture or stature, has to be given an option in the ascending format about the same, whether the same is being offered by the dentist or the doctor or not, or whether or not the patient can afford the same or not. That would mean if it is a missing tooth, your options would start from implants going to the RPD in that order, or even the reverse order can be followed, telling the patient that yes, implants are the best and the RPDs are the worst options. And obviously, you don't take class 1, 2, 3, 4 of the patients. Even if it is a sweeper, a daily laborer, you still need to give all the options. And another thing, even if you are not offering implants, someone is coming to your clinic or you refer someone, you need to mention the same, even that then as an option. If you are not doing implants, your options cannot start from a bridge for a missing tooth, just to give you an example. So the law says the two parties, 2 persons need to agree upon the same thing in the same sense. You understood what I said. What I said, you understood. Or what you understood, that I said. So that immediately means this thing only. So that the consent has to be without any pressure, without any influence, without any fraud or misrepresentation, because otherwise the agreement under the contract or the consent part would be then invalid. So consent has basically 4 separate but correlated elements. The first aspect is voluntariness. It should be a voluntary one. Then the knowledge, the patient should be informed. Full disclosure should be given to the patient. Capacity for decision making. He should not be, say, mentally retarded or say having any mental disorder not to be making a decision. And competency, he should be above 18 years of age, should be a major, not a minor patient. In minor cases, the parents make a consent. So to be legally valid, all these elements must be present in the consent. So what are the types of consent? Let me give you a little bit in brief about the same. Implied consent. It is an implied consent is when you are actually taking the same for history taking or general physical examination. In dentistry, you do not take a consent for checkup, because the patient has himself or herself walked into your practice, and then itself means that yes, the consent was taken for, because, or rather the patient himself says submitted or surrendered for the treatment. Then the expressed consent can be written, can be oral. There is no, you can take that if there is no implied consent or there is no risk involved. For a simple procedure like a class 1, if there are no side effects, class 1 cavity, you can take even a verbal consent, or a express kind of a thing can also be taken. So then it includes informed also. Ideally, informed consent is the written format, is always the preferred one. But for certain procedures, you can go ahead and take a oral consent also. So informed means you actually have to tell the nature of the condition of the tooth, or the nature of the proposed treatment, the benefits of the proposed treatment, the risks of the proposed treatment, and the available alternatives to the proposed treatment, along with the benefits and the risks. So the RBOs, alternatives mean the options only. So the RBOs, the condition, what you suggest, and the RBOs. The only thing is actually say mandatory over here, that these are the things which are valid. So the decision always has to be weighing against the risks and the benefit. If you plan to remove the third molar because of, say, it has developed pulp, it has been involved pulpily, but yes, there is a nerve loop going below the root of the third molar, and the patient is bound to develop paresthesia after the treatment. So you need to weigh against that, and the patient needs to know about it, about both the things. When there is little or no risk, it is called as a simple consent. You go about the decision making process, and the patient is given the information, and you sign the case together. It is actually as simple as that. But then here comes your knowledge and your discretion and your decision making skill, where you can actually have to make a discretion between a wrong choice and a good choice. The only thing is, sometimes we see a good case, we see a lot of implants, but the bone levels are not that supportive. The periodontium is not good, and the bone quality and condition is not good. The implants cannot be placed for more than 4 to 5 mm. So, and still the bone clear turns out to be a D3, D4 kind of a bone, even in the lower. So you understand, or you know that it is going to be a false case, or going to be a case where the failure is doomed, but you have an impending EMI at the end of the month. So what you will do, you will try to treat that case. And that is the first thing. When I learned implants in 2004 and 5, my boss told me one thing: learn to say a no. And that is applicable in the medical legal scenario as well. Always learn to say a no. The things which you can actually handle and control at the first step, you really don't need to go in for those things. In cases of emergency treatment where the patient has collapsed, where there is a road accident that has happened outside your clinic, you don't need any consent. If it is done for the saving of the life of the patient, you don't wait for the patient to come to consciousness and take a consent. Emergency consent has been disallowed by the courts as well. You should make the first attempt to save the patient's life in any situation, in any case. Don't wait for the consent scenario in the emergency situation. Then the tacit consent. If the patient doesn't say anything, silently or passively by omission, that itself means the patient didn't raise objection. So that would mean that it was a tacit consent. The patient kept quiet when he or she had an opportunity to forbid or refuse. So many of the people resort to a video consent also in their clinics. Perfectly all right. They can do that. But then if the patient does not has any objection, that would mean a tacit consent, and the patient cannot then deter away from that in those cases. So then there is a proxy consent, especially if it is for a child or a mentally unsound major patient, or anyone for a unconscious patient. You can call that a proxy consent or a surrogate decision maker. that consent is also valid in such cases where the consent is substituted for. In emergency cases, especially in cases of children, you can take someone who actually has brought the child from a school to maybe the guard, maybe a school peon, maybe the school kid handler. They have brought the patient to the doctor's clinic or hospital, and the parents are away to work. And the same can be taken from the school teacher as well. This is known as a locoparentitis. So another form of consent similar to locoparentis is telephone consent. In those cases, somebody like a school teacher has brought a kid, and you actually inform the parents over the phone, and the parents and the guardian who is brought is alternatively listening on the parallel line. So you convey the same, and the guardian says, yes, I also have been told the same. A guardian here means the school teacher or the attendant or the PN, whosoever has brought the patient in case of any emergency. So the guardian is listening, and yes, he gives in consent, and the guardian also says yes to the parent that I also have been given this option. In the meantime, the parents reach the hospital, the treatment can be instituted. So this forms kind of a telephone consent. So all the consents, again, voluntary, knowledge, competency, decision making, have to be still there, and again, that should be documented. I gave you an example. If a neighbor or a friend brings a minor to the dental appointment or even for a hospital, the parent can be contacted by phone and told that a third party is listening on a extension or a parallel line. So parents should be told of needed treatment, including all. They can sign the consent later on as well when they give the verbal consent. Obviously, if you're taking on a cell phone, you can record the same as well. So the consent discussion should be documented in the patient record and signed by the one who obtained the consent and countersigned by the listening third party. So then a follow-up letter should be sent to the parent or guardian, or maybe when they come, whatever has been done, and accordingly the signatures can be obtained from the patient. So for the dental, I mentioned when the patient sits in the dental chair, it should only be assumed that implied consent for a non-invasive examination has already been given. I see colleagues taking a consent even for a dental checkup. You can take it, but it is not required as per the law. So any invasive examination like a probing where bleeding might be involved, maybe occlusal radiographs. Sometimes for a normal radiograph, you can take an express consent. So it blood tests, diagnostic cavities, they would require a consent. And these all need not be written also. These can be express oral consents. So don't take a written consent for an X-ray or a probing or a diagnostic cavity or a blood test. This can be expressed. So don't treat the law as it is. Don't be too finicky about it. That is what I want you to carry home today. So then any physical investigation, you need to take a valid consent. So any doctor who does not respect this principle can be liable both by the patient to legal action and by the professional body like the DCI or the IDA as well. So touching a patient without valid consent is again can be a valid criminal offense of the battery. So battery means a criminal offense involving unlawful physical contact or which is distinct from an assault. So if there is no consent given and the patient suffers as a result of treatment, that can result in a negligence suit also. So you can suffer on two accounts. One, failure to inform the patient, failure to take the consent, and failure to perform your duty. That is the negligence, of course. So there is a reasonable physician standard. What a typical physician would reveal at the time of consent. Sometimes we would reveal only the desired things only, what only we want. So there are three things. What the law says, what the physician says, and what the patient says. So physician standard, patient standard, and the otherwise one. So what a physician would reveal or a doctor would reveal, and what information is actually appropriate to disclose. So mostly the physicians tell the patient sometimes very little. So reasonable patient standard is what the patient needs to know to understand the matter on hand and make a final decision, what involves his case. And a subjective standard, the lawful one. What a patient needs to know to understand to make an informed decision, because it is the most challenging one into practice because it requires the customization of information for each patient. So the subjective standard is the one which actually makes the informed consent mandatory in our practice. So then the degree of a probability of risk arising out of the treatment, the seriousness of the possible injury. These are the two important facts that the patient needs to know. Again, the risks, benefits, and the options just coded into a different form. What the patient needs to know about those cases. So the emphasis should be on the subjective standard and not on the reasonable patient or the physician standard. So you should best do your best to find out the patient's individual needs and priorities when providing information about treatment options. What does this mean? Actually, just translate into your clinical life. This means that you need to spend time with each patient. I have authored a book on patient consultation. It is a good thick book. What do you need to do? The first consultation, what importance does it carry? And then the consent part, I'm in the process of writing another book on that. It is completed 60-70% since 2013, not completed since 8 years, but now I have started that as well. It will be completed by the end of the year. But what I mean to say is that the patients, we need to treat and spend some time explaining them the things. If you have a OPD of 20, 25, 30, you just go on treating the patients like, say, regular laborers, I will say, and not actually like a doctor-patient relationship. We have to understand the seriousness of these issues, which actually have a great chance of affecting our professional and personal life if any mishap happens at our end. And remember, our record keeping and our documentation can be our only saviors most of the times. So then individuals' personal preferences, especially for the provision of care for the patients, they also need to be taken into account. And always the one line should be mentioned in each consent form that all the questions, all the doubts of the patients have been answered to the full satisfaction, and I have no doubt in my mind pending so as to proceed for the treatment. So patients have a full right to know whether their lifestyle will be compromised by any side effect of the treatment. For example, you all know there is a lot of hue and cry over the COVID vaccine only, because it has not been, the approval has not been given. It is only the emergency use authorization. So if the approval is given, you need to sign a consent for that also, that yes, is there any chances of ovaries being infertile for females, and say men getting infertile after maybe a loss in sperm count or whatever, as the notions have been, because nobody has seen the long-term effects. It is only a little less than a year that the vaccines actually got made. Last year in August or September only, they actually went into the first stage or the second stage trials. Mostly the second stage trials in the month of August and September. So it is a little less than a year only for that. There is no long-term data available on that. So we need to be aware of certain things, even if it's in dentistry, even if you're, especially if you're treating the anterior to the front teeth, if any of your facets can, if any of the treatments can actually change the smile of the patient, if especially if the patient is a social media person, a film star, or a public personality, and if it is bound to affect the patient's smile or looks in any way, then the patients have a full right to know that and decide accordingly. Because if it is affecting that, but that is mandatory for the patient, then the onus lies on the patient whether they want to go ahead with the treatment and get the required change, or they abandon the treatment and go ahead with the same. Obviously, when they don't choose to undergo the treatment, only they are to be blamed and not the doctor. Since the doctor did his duty of consulting, he hasn't yet started the treatment. But once you start the treatment, you actually cannot leave the patient midway. So not only do we have a duty to explain all the facts to the patient, but the language as well. NABEH guidelines say the consent should be bilingual, English and the language patient understands, usually the local vernacular. And it is not that if somebody is in Mumbai, he can use a English and a Hindi. It can be English and a Marathi. But if not going by the NABS guidelines, there, if the normal says the consent needs to be taken only in one language, and that language is what the patient reads and understands, can read and understand. It need not be only in English. If the patient is doesn't know English properly, but otherwise is well read, but is not very say in sync with the English terminology, then the patient has a right to be given the consent form in the local language which he or she understands. So all the additional points raised by the patient should also be addressed, and that note should also be entered into the consent form. Because there are a lot of things where actually intentionally we do treatment in good faith and then fall back upon to fall into a problem. So if the patient does not understand, it is the dentist's responsibility. The patient, if he says, I did not understand anything, they made me sign on blank documents, I really didn't understood, I haven't understood anything. So then the doctor is to be blamed. You have to be, that is where the role of the witness comes in. You can still lie, but 4 people cannot lie because the patient has signed along with 3 other people. So, but still, otherwise, also the emphasis should be on ensuring that the patient has a sufficient knowledge in that advanced step. Just to give you a demo of a couple of consents on endo and extraction. So, this is the kind of a thing where you actually mention what exactly is to be done, how you take about the photography part, and then the risks which can be there: post-operative discomfort, swelling, restrictive mouth opening, probably failure rate, or any dispute to malpractice, all those things. Then premature tooth loss, complication resulting from use of instruments, materials, medications, instrument separation, perforations, blocked root canals, incomplete healing, post-operative infection, tooth or root fracture, fracture, chipping, or loosening of existing tooth, post-treatment discomfort, all those things which are commonly there, they all can be incorporated in the body of the consent. You'll get bodies like this from net everywhere. So even for extraction, the common risks can be drug reactions, side effects, damage to adjacent tooth or fillings, post-operative infection, bleeding, swelling. So all these things would be mentioned as a side effect. But if the tooth was a class 1 cavity or maybe a little more than that, and you could have saved that tooth, where was that mentioned in that case I gave you an example for? Probably sinus involvement, nerve involvement, vein inflammation, breakage of jaw, any anesthesia allergies. So all those things can be actually a part of it. So this is the actual main slide of informed consent. What does it include? The purpose of the treatment. Why are you continuing to do the treatment for that tooth, or why are you doing that treatment in that particular tooth? The nature of the treatment, what it involves, the likely effects and consequences. So what all the possibilities can be there if you don't treat the tooth, or if you treat the tooth, all those situations that have to be encountered, and the risks, limitations, and the possible side effects, and options or alternatives and how they compare. And lastly, the cost part. Many people actually don't bother to add this cost in the consent, and that becomes a big bane of trouble in many clinics. And trust me, any clinic would find these problems very commonly. Many times the patient don't pay back that 10, 20, 30% balance which is left at the end of the treatment. The reason may be dissatisfaction, but then they don't pay back, or maybe out of human nature, bargaining, they'll do that. Remember, you need to mention cost, and along with that, a few of the clinic rules and policies. For example, you mention or you do a root canal in maybe single sitting and maybe in 2, 3, 4 sittings. You need to mention that even if it is in a multiple sitting, the charges are this. For a single sitting, the charges are this. But sometimes we have seen many clinics see that you open up, the patient comes in severe pain, you open up a root canal, the pain disappears, the patient also disappears for 6 months. The patient comes back after 6 months, talks about I had a family problem, so I could not this and that and this and that. Now it has started paining again last night. You do the dressing of that tooth, since the tooth has been open since many months now. So you do the dressing and tell the patient that yes, do get it completed now regularly. The patient's pain disappears, and the patient again disappears for 3 to 6 months. He again comes back with a different excuse. So you need to compensate for such appearances in your consent form very clearly, that if you don't get the treatment done, you will have to repay the charges. Because this thing, patients take you for granted that whatever time they will get the treatment done multiple times, they will be treated free of cost, or the same is included in your initial package with the italics, package of the treatment that many dentists offer these days. Sara treatment all the treatment will do in a certain amount of a package. So remember, each and every point would have a certain discussion in depth about it. Usually the informed consent session is a full day session of 8 to 9 hours. I take that in a separate workshop. But then this session is all about telling the importance of each and every point and how they compare. Just a little bit introduction about alternatives. Somebody had a front tooth to be treated. So he advised a root canal. Obviously, he did a root canal. Probably it was a white tooth. So the dentist did a manual root canal only, maybe preparing up to 60 or 70 number via hand K files and H files, a perfect seal, hermetic one, 3D filling, and he was able to achieve a good result. So the dentist made a note. The patient comes barging after 3 to 4 months. You did a manual root canal in my case. This tooth should have been treated with a rotary system. So who tells this? Our colleagues only. They dentists are made of different kind of soil. I mean to say, I've never seen any fraternity backbiting so much against each other as the dentist fraternity does. So it is a thing we need to introspect. Why are we doing that? But then we need to understand that again, the patient needs to be informed that a rotary or a manual root canal is a discretion of the dentist, not of the patient. It is not a choice of a treatment. It is the situation of the tooth or the anatomy of the tooth that decides that. But yes, you need to inform that, because certain times these things can sour the patient dentist relationship, courtesy our colleagues only. So informed consent does not happen when a form is signed. As I said, it is a process, not a one-time event. It is when a patient and a physician discuss a problem and choose an intervention together. So a process that takes place in one sitting or over the course of several encounters. We can also call it a shared decision making. Sometimes people would say that the patient does not bring anyone. So how do we get the signature of the witness? So that is a question that I usually answer, that I never start the treatment, especially for a long case, till the third or the fourth sitting. And for a normal case, never before the second sitting. Because for me, the patient consultation is more important. I need to convey everything. And if I have time, I'll convey about the consent also, and tell the patient that the next time we will start the treatment, but before starting, you have to sign the consent form. Some would say, no, I would want to read about the consent form. So please give me the consent form for signatures. So signatures happen in the clinic only. But yes, the patient can be given a copy of the same to read and go about that task. They will always barge you with certain questions. Nobody else does it. Why are you doing it? You always have to mention that this is a statutory requirement as per the law. I'm very amazed to see Karnataka State Dental Council has been one of the forerunners in applicability of various acts. I remember my medical law diploma in MLE was from National Law School, Bengaluru, way back in 2009 and 10. So Karnataka State had Clinical Establishment Act applicable in 2008 or 7 itself. I remember there was a question on CE Act in 2 of my examinations out of 4. So I wrote about it. So I was aware of the CE Act at that time. And in Punjab, the CE Act got applicable last year only in my state. So this is the thing. I remember I was doing a workshop in Andheri in September 2019. There was one participant from Bengaluru who actually on the first day of the workshop showed me at the dinner time, showed me a message dated 5th or 6th of September, that all patients are directed to undergo or to sign a consent form in the dentist clinic. And because that is going to be mandatory soon. And I really appreciate that the State Dental Council taking such an initiative. So it is a process, not a one-time event. So that is where the blanket consents are not valid. The consents forms has to be procedure specific, utilizing simple terms and avoiding overtly broad statements. So as I said, it is a full day workshop. Whenever I do, sometimes stretching up to 10, 11 hours as well. So blanket consents are not acceptable anywhere in the court of the law. What does a blanket consent mean? I hereby authorize Dr. Raghu Ganesh. Suppose, for example, I'm taking Raghu's name without his permission. So I authorize Dr. Raghu Ganesh for my treatment for my teeth under the effect of anesthesia, and I shall not hold him liable for any kind of damage that happens or occurs to my teeth, jaw, or associated structures. This is a blanket consent in one line. We see people having a stamp made of a similar and they just bear it on the patient prescription pad and get the signature of the patient. And the same prescription goes with the patient itself. And next time, mostly the patient will never bring a prescription. They, sorry, doctor, the prescription is lost. At least it happens in Punjab. I'm not sure about your state, but it happens in Punjab frequently every now and then. So you had one document which you give to the patient, and even that one signature of the stamp was even that with the patient itself. So that is not a consent. And then consent has to be taken before the medical action, not in the middle of the procedure. You cannot actually take it in the middle of the procedure. There's a very famous case of Dr. Prabha Manchanda. There was a lady who was actually 44 years old lady. It is a case of 1970s or 1980s, I guess. So Samira Kohli versus Prabha Manchanda. If you find time, do read about this case online. So Miss Samira Kohli was a 44-year-old unmarried female. So in those days, people used to say that the menopause usually happened after 55 in the older ladies in that time. So she was an unmarried lady, and she was supposed to undergo a gallbladder surgery. So gallbladder surgery or some other surgery for similar one. But during that procedure, some complication developed, and the ovaries of the patient had to be removed, or rather, I think the uterus or the ovaries, any of the two had to be removed. And in the middle of the procedure, the consent was taken from the patient's mother, who was outside the OT. So the patient literally became infertile and not able to conceive through the life, through her out to life, even if she was not married, even at the age of 44. So in today's time, the ladies have their menopause around 40 only, maybe 40, 42. Again, that is a matter of difference. So she went to court and actually accused doctor of the negligence, that I was not given a chance to present my side, even if it was a complication. Sometimes it could have been a life-saving complication as well. But then in a similar case scenario, that the patient was not given a chance, rather lost the chance of her motherhood of later in her life. The court took cognizance of that and penalized Dr. Prabha Manchanda. So this is the way we always say, in between the treatment, you cannot take the consent. It has to be before the treatment. Then another aspect is that you cannot leave the patient midway. The patient can do so. You are in the middle of a procedure, the patient raises hand, oh, I have a pain over there. Stop it. I don't want to continue. You inform the patient, yes, if you do it that way, it can have more infection, can maybe sometimes if you're doing a procedure which is related to bleeding, it can have more bleeding. You warn the patient, and no, I don't want to get it done. You are not a very comfortable doctor, and all your counseling fails, and the patient says, I want to leave. You ask the patient, please do sign here that I'm leaving against medical advice, a lama kind of a thing. So the patient says, I'm not going to sign. So the patient leaves, barging away from the thing. The patient can do so, but you have done the half the treatment and told the patient to pay off. The patient still does not pay off, and you are in a say ki no payment, no cure. That you cannot follow. You still have to continue with the treatment even if the patient does not pay you as per medical legal ethics, because otherwise it is a contract between the patient. Even if you have made the signature on the form regarding the payment, but that thing comes into action later on, that you have completed your side of the story, and that document can be handy to fight against if the patient does not pay you, especially if it is a big ticket case. It's an FMR case, 5 lakh procedure. You got the consents, you got the signatures done. The patient pays you 2 to 3 lakhs and say runs away after doing the other part. Then obviously you have the full right to go to the court with that document. That is where the document will come handy. But then the problem is in India is this, that again, my other specialty comes into play, finance. So people don't file accurate returns. So they don't want to mention the cost. If all the consent forms for the month are collected, their ITR would become, for a month, would become equal to their annual ITR what they file. So this is the problem in India as well, in most of those regards. So when you are actually utilizing an informed consent form, what all needs to be included in the top, along with of course, the other things that I mentioned, the consultation and the treatment protocols and the discussion with the patient, especially pertaining to the first consultation. So the legal name and the date of the birth of the patient. You don't write nicknames on that. What is legally accepted on the Aadhaar or the PAN card, which is there. Then the legal name and the relationship, if it is a pediatric patient, or if someone is consenting on behalf of that patient. So the patient's diagnosis, nature of proposed treatment, and of course the RBOs. Remember the word RBOs, and that is going to actually be very effective in those senses. So then professionally recognized or evidence-based options or alternative treatment plan, including no treatment. If the patient does not get the treatment done, what all the pitfalls are. Then again, a place for the patient to indicate, yes, all questions have been asked and adequately answered. And then places for patient or legal guardian, dentist, patient accomplice, and office staff member as a witness. So 4 signatures are to be there. The one who comes with the patient, the doctor, and your staff member, associate assistant, whatsoever. Education qualification does not matter in such a case. So what exactly is important in this is that the patient's competence to do so should be there. So some informed consent documents will contain language that would say that I will not hold my doctor responsible for any negligence in the performance of the treatment. Even if you include this, you cannot actually run away from your duty to perform the standard of care. You cannot actually run away from that. So these terms are known as exculpatory terms, and these are deemed invalid in the court. So people can actually bargain away with the merchants, but you can't do so in healthcare, as both parties are not in equal bargaining position in this line. Ki main doctor ko responsible, I will not hold him. So this is a unequal position of bargaining. And whereas when I started, I told you the consent means that the patient and the doctor are equal bargaining partners in crime, as I mentioned in a lighter vein. So if you express the same differently, it would actually say that either you agree not to sue me should I be guilty of negligence and you are injured as a result of my negligence, or I will not provide the services that I need. So these are the things you need to actually be very aware of, because these situations will arise with everyone. So the Supreme Court especially says in this regard that the doctor has an upper hand at the start of the treatment. He can pick and choose the patient. He can, suppose you have done the left side of the patient, taken the consent for, and because of some reasons, you know that the patient is not a good paymaster, maybe it doesn't come on time, maybe does not follow the instructions, is a little pain in you know what. So you don't want to continue with the right side of the patient, for example. So you can politely refuse before starting the right side once you complete the left side. So tell the patient that we are not comfortable treating you. So you can obviously part ways amicably. So, but yes, when you're treating the patient's left side, you cannot actually leave the patient's treatment midway. So that is a foregone thing. So informed refusal, I told you patient can refuse anytime. Person's right to refuse all or a portion of the proposed treatment after the recommendation from you, or even the alternative treatment options or the likely consequences of declining treatment have been explained in language the patient understands. You explain everything, the patient can refuse all treatment or even the partial treatment. I'll get the root canal done, but I will not get the crown done. You have a grossly decayed tooth patient, it can fracture. I really don't mind if it fractures, So you make a note of the same in that the patient's tooth is grossly decayed. The patient has been advised a crown, since there is very less of a wall or a tooth structure, a white healthy tooth structure is left. A direct restoration might not hold good, and there would be good chances of a leakage. So we advise a crown, the patient goes against it. So if the tooth fractures because of that, the patient, you won't say if the tooth fractures because of that, we will not be held guilty. You are no one to decide that. So you will say if the tooth fractures of that, the patient has been informed of those consequences, that if the tooth fractures, the treatment done earlier for as a root canal will also go waste. So you use such terminology and not the other kind of a court deciding terminology that if it breaks, I will not be held guilty. Don't go into that. You are not a judge to decide. Leave those things to judge. So an individual with the capacity or means the decision making or with the age or competency can withdraw consent at any time, including during the performance of a procedure. As I told you, In the middle of the procedure, the patient says, I'm sorry, I don't want to continue. You are paining me too much. Explain, sorry, we'll inject you, we'll make you counsel the patient, you try to reason it out. But then some patients are finicky patients. They will never understand all the things. Said, okay, fine. You tell them if you're leaving against your advice, please sign. They say, we won't sign also. So you make a note in your record keeping the patient left the treatment midway. In those cases, the patient will rarely actually accuse you of any kind of negligence since the patient knows that he or she is at fault. So then a patient who refuses to follow the recommendation should be advised of all the consequences of the refusal, verbally also, of course, in those cases. So if the patient recommends that a patient undergoes a root canal therapy and the patient chooses to have a tooth extraction, entry should be made in the patient's record and along with in the consent that the patient was informed of this. Remember, this can be very, very dangerous sometimes in many situations when the patient chooses to actually go to court against you. So if the consent has been obtained a significant time before the intervention, for example, people took a consent for a procedure in March 2020, and then we all know the lockdown happened. So if the clinics opened properly in June, some of them in July 2020. So is the consent valid in such cases which was taken in March? If there is no change in the physical situation of the tooth or for the whole treatment that you have prescribed, there are no physical changes, no breakages, no further spread, or practically bottom line, no change in your proposed treatment plan, barring a couple things here and there that you can mention or make alterations in your consent, you can still use that consent form which has been signed 4, 5, 6 months before. That can be still valid if the proposed treatment remains the same and if the patient's physical condition remains the same. So the law presumes that before the start, the doctor is in a dominating position. You can refuse the patient. I don't want to treat you. But once you have to obtain the consent, you have started the treatment, you have no reason to abandon the patient midway, including the payment. Usually we don't complete the treatment, the patient's payment would come and then only we complete the treatment. We are not allowed to do that. So consent is not a formality these days, as many hospitals get it done fatafat. Let's sign on a blank page. So it is not a procedure formality. It is a legal requirement of a medical and dental practice. So getting a mere signature on the form is no consent. And if a patient is rushed into signing consent without giving sufficient information, the consent may be invalid despite the signature. Especially if the witnesses are there, they can easily testify, yes, the patient did not explain a thing to the patient and the same was rushed into. So yes, you need to spend some good time with the patient in the form of first consultation and in the form of consent taking. So if you are ignorant of such things or any of your colleague is, you talk about whosoever 52 people I can see watching here and lot many on the Facebook page. So whosoever is watching and then they tell their colleagues about this lecture that Dr. Bhavdeep Ahuja said these things, and they say, ऐसे थोड़ा ना होता है, we don't know such things. So they, it does not mean if this was so mandatory, so compulsory, then people should have told us otherwise. So remember, ignorance is not a bliss. If you don't know, it does not mean that thing does not exist. So be very aware of such things. If you are ignorant, does not mean that the consent forms does not exist in this form. I told you already what all can happen if the consents are not customized. People ask me, please send me your consent forms. I always say, I don't have a consent form. Said, no, you're joking. I say, I always make a customized one right in front of the patient. It takes me 5 to 7 minutes to make that. There are a few ready-made set templates with me for every procedure. I have that. I just copy and paste, maybe add or two, 3 lines as per my requirement. And I just make a consent form within that time in 5 and 7, because I have the bodies ready. I have, if I need to work on the treatment costing part, then I take excuse me from the patient and I say the next, I have explained you everything verbally. The written part would be ready by next time. You have to sign along with a witness and then we can start. Obviously, what I've told you would be the same in that. You have full right to read it, understand it, and then go ahead if you are comfortable doing that. If you want that, no, next time I want to read the form first, show it to my husband, and then sign, you are allowed to do that as well. I'm in no hurry to start your treatment, because usually the patient is not in a hurry. Sometimes the dentist is in a hurry to start the treatment. So as I said, the consent remains valid for an indefinite period, provided there is no change in the condition or the proposed intervention. The example I gave you for the last year's lockdown. So always reconfirmed it. It should be reconfirmed at the time of the surgery verbally. If you have explained, physically signed. If it is a surgical part, you just explain once again. And again, the consent to be taken from the patient himself or herself. Remember the Samira Kohli and Prabha Manchanda case. So no one can consent on behalf of a competent adult. You can do that for minors. You can do that for mentally unsound patients. You can do that for uh, uh, people who are in inebriated condition. But for competent adults, you cannot consent. Anyone cannot consent on their behalf. They have to sign it themselves. So consent should be free and voluntary, and it is said to be a free consent if it is not by any pressure or coercion, any undue influence, any fraud, any misrepresentation, or by any mistake if it is there. So again, the important thing always remain the three words RBO: the risks, benefits, and the options. So the patient has a full right to a disclosure about his condition, his prognosis, the treatment benefits, the adverse effects, the available alternatives, the risks of refusing treatment, and the approximate treatment cost. When all these things are there, then all these things need to be put in black and blue as well, in the writing as well, in the consent form as well. Consent has to be procedure specific. I showed you two examples of endo and extraction. So if a consent is for a diagnostic, it cannot be a consent for therapeutic treatment. And of course, consents during the course of the surgery is not acceptable. Blanket consents are not valid, like the one I mentioned, mentioning Dr. Raghu's example. Just not example, but to naming him without his consent. I mentioned Raghu. I know I can trust Raghu in this regard. And all encompassing consent, I authorize so and so to carry out my treatment, and in the course of my treatment is not valid. And along with that, if I will not sue him for anything. Remember, I will sue you is a very common word in Western world, but it is becoming common in the Indian scenario as well. So always for a repeat procedure, a fresh consent should be taken. The beauty about the consent is that even if it is a repeat procedure, you don't have to undergo that lengthy process. You don't have to of explaining each and everything again and again in a meticulous manner, since the patient knows it. If it is an old patient, then he also knows the system of your working. So that is the reason sometimes for my old patient, for the same procedure, I did a root canal for a patient this side. Now I'm doing it from this side. The patient is the same. He or she knows my rules. So I'll just pick up the old consent of that patient only, copy and paste, just change the word 36 to 46. For example, if it is for the first molar right and the first molar left, I'll just change 36 to 46, and accordingly, the remaining of the things should remain the same. So there is not much of a difference. If the complication level, maybe the fracture level, maybe the anatomy is different, then I do make a note and do inform the patient as well that these are the things that are changed in this, and you should be aware. Usually in old patients, in people like my practice, I'm into 22nd year of my practice, these things don't take much of time, since many of the patients are repeat OPDs. The new patients know the system of working, especially the referral ones. So it is all interconnected chain only, if you are able to understand. So witness consents are legally more valid in court of law. You can still go ahead with the consent of a doctor and a patient. But if it is a witnessed one, remember, it is more creditable in the court of law. The patient is free to withdraw his consent anytime, even during the performance of the procedure. Then if the patient says stop it, you have to stop it. So you can address the concern and continue the treatment only if the patient agrees. So I've repeated certain things again and again to make the concept pretty clear to you. So consent is no defense in cases of professional negligence. You say, I had the consent. Consent does not give you a license to do negligence. Consent only means that you can touch the patient after his signature, after his consent, after his approval. It does not allow you to go beyond a certain standard of care, which is the gold standard in the cases of negligence. Since negligence is a separate topic it's a separately 3-4 hour topic. So I've just added a brief introduction here about this only. I'm not going into much detail because that requires further intervention for that. So consent is not fixed with a good form. It is always customized. I hope you understand what I mean by customization here, because each conversation with the patient is unique. Each truth is unique. Each situation might be differing from one patient to another. Your way of talking, your proposed treatment plan, your prognosis, the patient's condition, the patient's paying ability, the total treatment cost. Rarely you would have two kinds of similar patients going on parallelly in your clinic. Usually each case is a different case one. So even if it is a complete denture patient, the case would be totally different sometimes, even if the outcome is same. So always preferable to take the consent in the patient's vernacular, and desirable to use short and simple sentences, non-medical terminology, and preferably it should be typed legibly. It can be written also, but prefer, it is a smart age, it is a digital age, prefer a typed one usually. Everyone of us have a PC or a laptop in the clinic, so there is no point in actually going over there. So if you are tired, I'm coming to the end of my presentation. Just to summarize a few things. So it is not only ethical to impart correct and necessary information, but also important that it is a legal requirement in today's times. So this communication should be documented always in most of the cases, except where it is the express oral consent which is taken. So even sometimes the PI insurance will not cover for lapses for not obtaining a consent. They may consider it to be an intentional assault. Sometimes they touching the patient without the permission of the patient can be considered an intentional assault. If you don't have the signature, how will you prove that you took a consent, especially for a large case? For a simple express oral cases is fine, but where the risks of the treatment are involved, how will you prove that you actually touched the patient without the permission? So it can be considered as an intentional assault. The good faith phenomenon does not come in over there. For those who want to know more about professional indemnity insurance, I recently covered it in 2 videos. That video should be online in the mid of July on my YouTube channel. I'll be giving a link at the end of my presentation, so do follow that. So what are the 5 things that you need to do? Communication, that would mean the first consultation. Documentation, talking about to the patient and putting it in black and blue, that is the record keep. Then the communication of documentation, you verbally explain the patient about the consent part. Then documentation of communication, the consent is put in black and blue. Then preservation of documentation, that documentation is to be stored minimum for a 2+1 3 years time. That is requirement as per the law as well. Physical forms have to be stored. I always advise physical forms are there, scan it up and then store it in your system, and then probably store it in your in whichever way you want to, in your store area, in your record keeping area, in your lab area, in your kitchen area, wherever you want to. So why actually dental patients sue their dentist? So this is a study from Forensic and Legal Medicine Journal. Wrong and pleasant outcomes, pain, swelling, bleeding, fractures. So being negligent during treatment or documentation, wrong tooth treatment, consent related issues. It is constitutes 25% of the suing effects. So I will sue you effects. So on case sheet and records, the journal says poor record is poor defense, no record is no defense. It does not mean how good record keeping you have pertaining to patient records. If you are not maintaining say consent part, that is also equivalent to no records in majority of the cases. It has been observed in judgments that the focus is on the treatment method formulation and execution rather than the treatment outcome alone. How you reach the destination is more important than actually the destination itself. So I hope you are not in such a situation right now. So let me give you a summary before we wind it up. So dentists have to use their skills, knowledge and experience for the improvement of dental health of public, and due considerations for patients' needs, desires, ability, and of course, patient's privacy. I told you about the principle of confidentiality and fidelity. So then we have a duty to be honest and trustworthy in our dealings, the principle of veracity, truth telling. We are not in a perfect science. We all know that. So the treatment should be conforming to the standard of care. The standard of care means you have to follow what the courts don't expect us to be Hercules. They will expect us what a reasonable person under a reasonable set of circumstances would have done. So we are expected to do that only. So it does not mean that if we fall below the standard of care, we are actually going beyond that. So treatment below the standard of care is negligent and can be a ground for malpractice claim. So usually, the problem comes there only, that usually malpractice issues will involve the failure to diagnose, the failure to treat, a timely referral where you wanted to jump beyond your skill set, beyond your professional ambit, and of course, the general dentist attempt to treat beyond their level of competence. Learn to recognize what your boundaries are, learn to recognize what your limits are, and do not actually go beyond them. So thank you so much for a patient hearing. Just a couple of announcements before we I stop my presentation. So this is my YouTube channel that I was talking about. As on today, 20th of June, the number of videos have crossed 300, which are there on different topics of practice management, medical legal aspects, and finance. There are a lot of short videos. There are a lot of webinars on each topic, and I started a new playlist in just 2 weeks back only on motivational videos. Small 6-7 videos on motivation are also there. So just today only I launched 3 videos and one last night. So 4 videos were there in the past 24 hours itself. So all those combined have 300 plus videos. And remember, I'm a very camera shy person. I had never faced camera. I was say fond of even taking a selfie also. But the first webinar I took was on 25th of March 2020, almost the first day after the lockdown, national lockdown that happened last year. And in that 1 year, obviously not all were recorded also, but till date 300 plus done, and more than many were there which were not recorded itself as well, which don't have any record. So this is my YouTube channel link. My social media is by my name only, Dr. Bhavdeep. So go to the channel. If you forget it, just search my name. You'll find it. Subscribe to the channel. Hit the bell icon because I post a video daily. Dr. Raghu knows about it. He's in my groups. I post a video daily. So this is my phone numbers, email, and website. You can get in touch with me on this. So my social media presence, as I said, all goes by my name on FB, Insta, Twitter, LinkedIn, except on Facebook page, which is by the name of Dr. Bhavdeep Ahuja. So I run 2 WhatsApp groups as a part of my CSR activity, my corporate social responsibility. Although I'm not a CSR, not a corporate as such, I run WhatsApp groups for my community, free of cost education. It's been 4 years now. So I plan to keep it till 5, but then I had to give in to the request of a few. So the 6th group is on. I have named it as a temporary group. So anyone misses out here, I add people from here to here. So these groups are running. I'm managing these groups as well. A free education is there. If you want to be added, you can send me a message on my number. I'll add you into those groups. So do send me a valuable feedback in your idea group also. I know Dr. Raghu will forward all of them to me. So whichever you want to, bouquets and brickbats, both would be welcome in equal measure. Whatever you had to say about my presentation, if you had any carry home points, I'll be surely happy to inculcate them. And that gives me a scope for improvement in further presentation. So thank you once again. And I stop my share for any queries. So let me see the time, exactly 8:40. So I'm right bang on time because I know my presentations, how much time will they last. So firstly, I'll be taking up the question from the chat, and then I will take up the questions from the live audience once I have answered them fully. Okay, let me go up first. Now, Dr. Raghu, in the meanwhile, please check out if there are any pages on the Facebook page as well. Once I answer these, then you can check up from the Facebook page. I'll take up the queries from there.
Yes, sir. So far, no questions in Facebook,
Okay.
sir. I'm following it.
Thank you. So Dr. Ramlal asks what all the things to be needed in written consent form, customized consent form. So I think this was a question at 7:33. So I hope Dr. Ramlal, this question has been answered by 8:40 p.m. I guess now. So what are to be added in the customized consent form? So I'm not going into that. So Dr. Pooja Ranka asks, do you suggest having a common consent form and a customized consent one for different procedures failures? I think I also answered this part. You have to have a customized consent form, a different one from each procedure. I just gave you two examples as well. So usually my presentations encompass usually all the questions, but yes, I still want to welcome questions if they are still in mind from you. So Dr. Rajsekharan asks, kindly do let us know that the procedure that shall be taken up on the first visit. Usually the procedures where you feel the risks are not much, where you feel the express oral consent can be taken, you can go ahead with those procedures. For example, a class 1 cavity. Never think of scaling or a prophylaxis to be a first sitting procedure, because wherever the bleeding is going to be involved or the medical complications can be there, or any systemic diseases the patient is suffering from, that thing cannot be taken up in the first sitting for sure. So do take those things into account. So Dr. Ramlal again asks, how long should we keep hard copies of written consent to maintain its validity in court of law? Is digital consent form valid legally? I answered that, Dr. Ramlal. We need absolute requirement is 2 years, but 1 year we always mention on the safer side, because my lord, the Judge Saab will always allow 1 year up to condonation of delay. So we say for an absolute safety side, record keeping is to be mandatory for 3 years from the date of the procedure that has happened. As regard consent, digital consent is not valid. You have to take a physical consent, scan it, and then do it. As of now, you cannot. Video consent is still valid, but a digital consent in the form of a digital signatures is not valid as of now. It may be a reality in near future, but as of now, you have to have a physical signatures for that. So is there any guideline or metrics to standardize the customized consent form? Dr. B. Sabranith asks. Dr. Sabranith, the problem is that there is no metric to decide that. It is a customized thing according to your consultation of the patient, according to the case selection, according to the prognosis, according to the proposed intervention. So all these things will actually decide the guidelines, and not a gold standard is there. The gold standard guideline with the 6 guidelines that were there, I gave in the presentation itself. So you can revisit the same on my FB page. Obviously, Dr. Rajsekharan and Dr. Raghu would place the same video on the YouTube channel as well in a few days. So you can revisit this video, that those 6 points are there, which all need to be taken care of while doing that. So can a scanned copy of the original consent is valid? Yes, of course, it is valid. Dr. Prem Karthik's question. So in case of lost original form, yes, it is a still valid one. So what is maximum time duration? They have to be retained as original copy 3 years. 3 years is the absolute time. So Dr. Ramlal again says, what if patient disagrees to written consent? Do oral health practitioner has right not to treat them? Yes, that is what I mentioned. You have the full right to refuse the patient before the start. I always say it is my clinic, my rules apply. If you can't assert yourself in your clinic, then what is the fun of running such a clinic? You don't bow down according to patient's wishes. You have to decide your treatment. You are the boss, you are the doctor, you decide what is best for the patient, not the patient. You never stoop down to patient's level for the proposed intervention. I gave you an example. The tooth is bound to be extracted. Furcation involvement almost there, almost about to be separated. The patient says, please save it, even if for 2-3 months. But once it is saved, the patients turn into turncoats. They become different personality altogether. That it just lasted 2 months, you never said so. So they will behave like that also. So always be on the safer side. The documentation is your savior most of the times. So Dr. Kavita asks, if a patient asks the copy of the signed consent, can we give? Yes, the patient has right to all the documents in your practice. Whatever, even your OPD cards that you maintain for your own record keeping, if you're doing a manual one, or even if you're doing a digital record keeping, the patient has full right to ask for records, and you are liable by the law to provide the same within 72 hours of the request. In 3 days, not in like the banks, 72 hours for them means 9 days or 9 working days sometimes. And that would mean sometimes 2 weeks also. No, they don't count Saturdays and Sundays in that. For us, 72 hours means 3 days. And yes, you can still charge for those copies from the patient. The Xerox charges, the printout charges, you can charge that. Of course, that is a very small amount, but the courts, the law allows you to charge for that. But yes, patients have a full right to get the same done or sorry, the same to be taken from you in that sense. So, okay. So Dr. J. Sudha asks, should the extra points be written by pen or type before starting the treatment? Usually I prefer a typed one, but if you're making a changes by the pen, like the bankers do on the side, vertical side of the flip the side of the form orientation and get the sign on the side of the form itself, then you can get it done if you have made any additions by pen. But if you have done it in the typing mode, then it is best to have it or take a reprint out of the same. That should be always there. So is digital and video consent accepted in the court of law? Yes, video consent is acceptable in the court of law, especially for the patients who are handicapped, especially who are on a wheelchair or have a Parkinson kind of a problem where they can't actually sign. In those cases, video consent is valid, of course, surely. So Dr. Prem asks, are handwritten consent forms valid? If the patient comes alone without his attender, what can be a witness then? So are handwritten consents valid? Yes, they are valid, but it is a digital age. I would not assume that you're spending so much time writing the consent forms, and especially if it is a big one, don't waste too much time in making a handwritten consent ones. The typed consents are a better option. If a patient comes alone, I already answered that. Who is in a hurry to start the treatment in the first sitting? At least not me, of course. So if I am not in a hurry to start the treatment in the first sitting, why are you in a hurry to start the treatment? Always remember that line. We need to know that the doctor and the doctor and the patient agreed upon the same thing in the same sense. Unless you both are on the same page, do not be in a hurry to start the treatment. So who can be a witness? Tell the patient they have to sign the form next time. Always start it next time. So what if the patients refuse to the third party consent? So if the parents refuse to the third party consent, then of course you cannot do anything but to refuse the treatment. Of course, there will be rarely a scenario if the patient's child is suffering and the guardian or the school teacher or the PN has brought the same to the clinic or the hospital. I don't think a patient would refuse a treatment in that case. More or 99.9% they will not refuse it. But for any parent, a kid is usually the first, first love to be treated as such. In that sense, they never want anything should happen to their kids. So out of love and affection, they will never refuse it, especially if it pertains to any emergency. But if they refuse it, yes, and if it is an emergency, you don't wait for the patient's consent in such cases. You institute the treatment because in emergencies, you don't require a consent. But if it is a normal procedure, for example, the child has fallen down and is having a fracture, but a favorable one, not a dislocated one, a fracture, and he might be in pain. You have given a painkiller already as a part of emergency treatment. There is no bleeding or pain or swelling as such, majorly pain you have taken care of. And the parent says, no, I don't want to get it treated over there. So the parent says that. Obviously, then he has the right to choose that treatment. But if the patient is bleeding profusely, no parent would say, nahi, I don't want to get the treatment done. They'll always say, please start the treatment immediately. I don't want anything happen to my child, of course. So rarely that would happen. So a similar question by Dr. Gayatri, what if the parents refuse? Same one. Dr. Prabhu asks, sir, if we don't get consent in the emergency and something happens to the patient, they may blame the doctor now, sir. How can we handle this? No consent is required in emergency. That is as per the code of the law. That is as per the Supreme Court guidelines. You have done everything in good faith to save the patient. Nobody can challenge you anything. I told you, God forbid any accident happens outside your clinic. So rather, if you don't do anything, then you may be liable. that you being a doctor still did not do any CPR or any kind of a, say, clearing of the oral cavity. If any, say, foreign body had fallen in the throat and maybe the tongue had fallen back, the patient was not able to breathe, you did not do anything, or maybe a bleeding was happening, you didn't do anything to arrest the bleeding, then you may be liable. Of course, if you're not at home, then you can't be liable, of course, in those sense. But as a human being, otherwise, your moral duty is to help someone in distress. In emergencies, you don't wait for the consent. So you always make the first attempt to make the patient comfortable first. So what about other state patient who does not know English or the local language? Usually then the role of the translator comes in. So somebody who understands both the languages. So that is the way to go about in such cases. But then usually English is the common language. If the patient does not understand even English, then the translator has to be employed for such purposes. So patients don't value the prescription and mostly don't bring it again, in spite them told to bring them next time. Yes, they will not bring it, of course. As I mentioned, some people take a blanket consent, and that too on the prescription of the patient also. So, okay, Dr. ADM Malar asks, sir, who can sign the dentist side witness in the clinic without dental assistant? I don't think any dental clinic functions without any assistant usually. But then usually associate, assistant, or anyone who is actually working and can sign on behalf of the dentist witness. It has to be there usually. So Dr. Dinesh asks, how about explaining to patients who complain that a wrong tooth has been treated or extracted even though the right one is treated? That is where the role of consent comes in. You take an X-ray, the documentation is there to save you. If you have extracted the 6 and you have a preoperative X-ray that it was decayed, badly decayed, the patient may be complaining of pain in 7 because of the adjacent tooth pain. Sometimes the referral pain is there, but you extracted the right tooth, you have the preoperative X-ray, you have the consent. Let him go to court. He will never go to court because he knows it. Yes, the pain might be because of other reasons, but if you have instituted the correct treatment, you don't need to worry about that part, especially in those cases where it is a trivial kind of a treatment. That is the reason I always say filter out your patients. Never always be in a hurry to treat all or do all the patients always. Okay, Dr. Malar asks again, can only assistant dentists can sign witness of dentist side? Can some other sign when we don't have one? Assistant dentist, assistant of the clinic also can sign. Those who are chair side assistants, I mean to say. So it does not mean only the doctors can sign, even the chair side assistant can sign on your behalf. So Dr. Raj, it is hard to believe that you are camera shy. I am extremely camera shy. The camera hates me and I hate it doubly back. Really so. Can customize part of consent handwritten? I advised a typed one. I don't advise a handwritten one. That is a personal choice. You still want to say spend time in writing certain things. You have the body in a typed form and the top and the bottom in a say handwritten form. It'll take a lot of your time. I'll avoid that. I'll always avoid that. So is the cost of the consent to be got every time? I didn't understand the question. Is the cost of the consent? There is nothing cost of a consent as such. I didn't get the question. Please do clarify, Dr. M. It is a direct message.
Maybe the cost of the treatment should be added in the consent, sir, every time.
Yes. Okay. Cost of the treatment and the consent. Yes, the cost of every time when you're taking the consent, you have to give the patient an estimate for the treatment. Always do it. Always do it. Because and since if you want to say that the procedural cost is non-refundable, if it is varied on certain factors I gave you for endo, for example, people will disappear after the first sitting. They'll reappear after 6 months when the pain starts. So you have to mention your terms and conditions. When you have not mentioned the total cost, then you have to. That is the reason I mentioned. If you collect all the consent forms of a dentist for a month, that will become the total value of the ITR of the patient or of the dentist. Whatever, if he is charging or say filing his ITR, would be the same value in a month. That is the amount of say tax chori we all indulge in. So is there any specific format for ortho patients, the validity of ortho treatment consent forms when they come for relapse later? Obviously, there are formats for every kind of thing. You will always have all the bodies available. But then the relapse is a side effect of the treatment that has to be mentioned along with the T and the C's, that it depends primarily on the retainers part. If the patients don't wear the retainers properly, it has a huge potential to relapse. Otherwise, also sometimes in a skeletal case, also the relapse cases are very common. So when the corrections are there, so you need to mention that clearly. And please re-stress on the duration models should be stored. Yes, all the records, whether it is CAS, OPD records, your case forms, your X-rays, everything, even the lab models, for 3 years they are to be stored as a record keeping part. So there is no two way. Where will be stored, that is up to you, in your house, in your garage, in your clinic, in your bunker, wherever you want to. It is a personal choice. So is extraction consent should be got every time the patient comes for new teeth? Yes, surely. You just need to change the tooth number only. The patient is an old one. You don't need to explain each and everything again and again. The patient knows it. Get the same done, and you get, and the patient also knows it, that he needs to sign a consent form. See, he or she will already bring a witness along with. When they know your way of working in the practice, you need to make a system apparent to the patient. So all these aspects of practice management, all these are formed available in the video format on my YouTube channel as well. So do subscribe to the channel till 2nd August. Daily, in the past 1 year, almost daily a video has come. Even just today, Sunday, there are 4 videos that were online. So every day, minimum 1 video is there online in the form of a long video, short video, or a webinar. So do subscribe to the channel. You will be notified every day. Until as of now, as I'm speaking on 20th June, videos till 2nd of August have been already scheduled. I don't do anything. They come automatically. Whenever this webinar is to be taken up, that will all automatically scheduled in the queue by tomorrow morning. So you don't have to worry about this part. So you might see this on your YouTube channel earlier, because on my channel it will be scheduled around the 1st or 2nd of August only. So whenever it comes over there. So how far the signature of the patient is authentic or refuses that it is not his sign, and how can we prove in court of law? Dr. Nagarajan, that is the thing we need to understand. One who signs in the presence of 4 people or 3 people other than him, he will think twice or thrice to actually backtrack from his treatment, from his statement. You can always say, yeah, this is not my signature to one person. When 3 people have signed together or 4 people have signed together, it is very hard to refuse that. So don't worry about that. But you don't need to prove it. They have to prove it that it is not their signature, or whatever they have been. It has been forged. So if that, then that would mean that the witness signature also has been forged for both the cases. So it will be very difficult for them to prove in such a case. So if a different, and I told you, we don't go into such thing. We don't, for the reason of consent, we don't go to the court. We reasons of not taking the consent, we can go to the court in such cases, because most of the time the patient will absolve, I was not told of such things. So as I told you, the courts are not competent enough individually to decide upon such. So they refer it to an independent medical or a dental board who decides that whether the treatment was followed was up to a particular standard or not. And in such cases, the board will decide, the board will ask for the documents, and the documents of consent taking will itself decide, yes, whether what the treatment recommended was, it was actually standard of care or not, whether the patient was informed of all the RBOs or not, so that the consent will automatically take care of. So the signature thing will not only come into being only in that path. In any case, when there are 2 signatures of witnesses, it is automatically a more credible thing in the court of law. So don't worry about that part. It is a differently abled patients come alone to the clinic, how to explain him or her and get consent. I told you, Dr. Gayatri, video consents are valid in cases of Parkinson's and cases of differently abled patients where the signatures can't be made. The video consent is valid. And yes, the same can be taken from the patient along with the companies that say, yes, every question has been answered and they have been informed about such cases in such scenarios in those things where we take those things into account. So that is the situation. We need to understand that we will get a problem most of the times when we don't adhere to the requisite set standard. Okay. What happens if the orthodontic patient leaves in middle of the treatment and asks for refund? Your consent is your savior. If you have mentioned no refunds issued, dissatisfaction is not say reason for that. But yes, if you have fallen below the requisite standard of care, that may have become a ground for malpractice or a negligence. But a refund thing, you have mentioned already clearly, witnesses have signed that this treatment is non-refundable even if you discontinue the treatment. That is where the role of customization comes in. Your treatment conditions, जो rule आपके clinic में है, whatever rules exist in your clinic, that have to be in black and blue. For example, just presume I have a rule that if you discontinue the treatment, I will pay you back 50% of the refund. Your clinic says even if you discontinue after 10% of the treatment done, 100% charges would be non-refundable. It can vary as per clinic. So that is where the customization comes in. Each patient is different, each dentist is different, each clinic is different, each situation is different. So you need to understand all these have to be a part of that consent form. So that is why there can be no two common consent forms. It is always customized. So Dr. Sudha asks, what about the concern from the patients who come from old age homes and hostel? Did not get the question. Concern from patients who come from old age home and hostel.
Like those who don't have a guardian, sir, who cannot sign for them, or they cannot bring someone along.
In those cases, whatever they're even friend, it is not always that a relationship has to sign. It can be a neighbor also, it can be a friend also. It can be a accomplice in that old age home as well. If it is in a hostel, it is a minor. In those cases, the guardian is needed. The minor cannot sign, surely. Okay, Dr. Vignesh, thanks for great session. Do we need informed consent for all dental procedures? Is the standardized template available for each procedures? If not, should we not have one by DCI or IDA? Of course, only body of the content and having space for customization. IDA has a few at their website, Dr. Vignesh. Again, I'm not very happy with their whatever are available on their website. DCI does not have any. Yes, it is their duty to specify. I gave you an example of the KSDC, Karnataka State Dental Council, which has actually, I don't know whether they have that form or not, but yes, they made it mandatory for the dentist. But then you get the consent templates everywhere.
We have, sir, for our branch, we had got a set
great.
of custom forms. The body part.
The body part. Great. That is great to hear. I mentioned at the start, yours is one of the most meticulous and organized branches. We also need to take a lesson from your branch.
Thank
so
you, sir.
do we need informed consent for all dental procedure? Yes, we need consent for all dental procedure, express very small procedures where the express thing can be done. It is a checkup, it is a complaint kind of a thing. It is just a overall. You don't need consent for such cases in those scenarios. So don't worry about that part. So, okay. You asked for the cost of the treatment and consent. No problem, Dr. Ramni. So Dr. Gayatri asks, in case of emergency content, what it contains? Emergency, you don't need any consent, Dr. Gayatri. There is no consent required in emergency. You don't mention what is required in consent. We don't need any consent in emergency. Only a treatment procedure along with region or consent. Nothing is required. Everything is done in good faith just to save the life of the patient sometimes. You don't need anything for emergency. So don't bother about that part. So Dr. Vignesh, do we need anything other than ICF mandatory by court of law? ICF, informed consent form mandatory by court of law, medical records, case history. Yes, these are the basic things that are required. Yes, all those other investigation reports, any x-rays, any lab models, any casts, if any needed by the law, if any needed by the court, but those are needed only in cases of negligence cases. Stick to your desired standard of care, standard of care, and you will not see the face of the court in any near future. So don't bother about that part. So those are also requirement to be produced if you happen to fall into any negligence suit, not otherwise. So what's your take on fingerprint signature to avoid later issues? Yes, that is again a debatable thing. Nothing wrong in that. If you don't want to take a signature, you can go in for a thumb impression, even in cases of a literate person. Nothing wrong in that. But I am getting signatures done. I haven't faced any problems till date. But yes, there is no bar. Instead of signatures, you can get a fingerprint done. Since people believe that fingerprints are unique. So yes, again, no issues in that. You can get that done as well. So what needed to be added for COVID? Nothing especially for COVID. If the situation of the patient, because there are no guidelines available as such, there was a hoax message floating around that in the recently treated COVID patients, you can't inject an LA. So that if that is the situation, then I might have killed at least 50 patients by now, because I've treated 50 positive by now till now, but this is the thing we need to remember, that it does not need to be added in specific, because since we don't have any clear-cut guidelines as such. So, and nothing by the DCI, nothing by the Government of India, nothing by the MHF, Ministry of Health and Family Welfare. So we can't actually say what exactly needs to be done. So in video consent, how do you record the date of the conversation with the patient? It is very simple. You get a settings, you go to the settings, add a date imprint on that. Even in my YouTube video, this Zoom video, which is being recorded, it is recorded with date imprint on it. Once it comes on your channel, on your branch channel, check it out. You will have a date imprint. It is just a setting in the camera itself. So there is no special thing about it. You can still alter it, of course, but then it needs to be proved that the date was morphed. So don't worry about that part. It is an impinned one as well. So thank you, Dr. Sudha. Thank you, Dr. Prem Kumar. Is digital signature authenticated? No, you don't. As of now, not. You require a physical signature or a thumbprint to be on the safer side if you are not very clear about it. So, Dr. Anand, thank you, Dr. Anand. Dr. Vidya, thank you for this session. Dr. Gayatri, thank you. So, any more queries, or if I missed any?
Sir, myself, I have a question, sir.
Yes, sure.
Sir, actually, it's really very hard to believe that you are a camera sir, and you made your first presentation by March 2020, if I'm right.
Yes.
For the past 1 year, it has been so good for you, and the way you articulate words is tremendous. The thing is that, if I'm right, you said that if it is mentioned in the consent form that that you may not be sued for any negligence, something like that, between the patient and in the consent form.
That was
even if it is mentioned so that you may not be sued for so and so for medical negligence or whatever it is, even if I found guilty, will it be accepted in the court of law in India right now at this moment, if at all there is any negligence or so-called negligence or loss or whatever it is?
The words were that consent is not a defense in cases of negligence. The consent form is not your defense. Consent is only a permission to touch the patient with his wishes, with his approval. Consent does not give you a license to do anything. Consent only gives you permission to do only the suggested protocol that you promise to the patient, and you fall under the Indian Contract Act 1872. You two parties are agreed on the same thing in the same sense. Doctor, you will treat my tooth like this. You will build up my tooth like this. Just an example. You build up like tooth like this, like a triangle. Let's suppose you will build up tooth like this, but in the end you build it like a square. So that is where you breach the contract. If you say no, this is the correct one, I promise this only. No, doctor, you promised me a triangle. You built up a square. So that is a breach of confidence. A contract is there, and the patient can go to the court that yes, in the consent or whatever, I agreed to the treatment because I was promised a triangle. I in the end have got a square. So I'm sorry, this is breach of contract. This is breach of trust. So the doctor, I need to sue the doctor. And then the doctor is negligent. The doctor will say in defense, the triangle was not feasible. I didn't know how to make a triangle, so I made a square. Or maybe he'll say in a different form, the square is the best suited for that position. It will give patient a better comfort. But what you need to comply is, if the square was suited best, you should have explained the best that to the initial phase. And the patient agreed that yes, I will get a square in the end. Why did you say a triangle first? Just try to just imagine that situation. So consent is a thing to touch the patient and not give you a license to do anything that you want. You're still required to stick to the desired standard of care, the subjective standard of care that I mentioned. Full disclosure, and that is the reason, and you treat the patient accordingly. The patient, still, even in this situation, the courts will not expect us to be Hercules. They will expect us what an ordinary man under an ordinary set of circumstances would do. We did that. We don't expect a specialist job to us. But yes, here also we need to realize that we don't jump beyond our skill set. We do not attempt those things which do not fall under our own, say, skill set ambit. Wherever we know that I can't do this procedure, you know, inside, draw a line, call a specialist, or refer the case, whatever is best suitable to you. So I hope I answered your question.
Yes, sir. But because most of the cases, most of the situations here is the law is more friendly towards the consumer, if at all it is.
Surely the law is more friendly towards the consumer. Surely, I agree that. But the problem is that your documentation is your biggest defense. If you have good record keeping, if you have good consent form, and you stuck to the desired standard of care, nothing or no one can touch you. Don't worry of that
Thank
part.
you, sir.
Okay, thank you, Dr. Umashankar sir. Thank you, Dr. Vignesh. Any more queries? I have one query on Facebook, I guess. Dr. Vrinda, she mentioned has a query last night also. Can you share a proper consent form? Dr. Vrinda, the consent forms are surely customized. I mentioned it before also. So they are not a proper consent form. A proper consent form is a customized consent form. So don't worry about a proper consent form. You have to create another one for your own.
Sir, sorry to interrupt. At
Yeah.
least for the beginners, at least the body of the consent form, at least.
Google it.
Yes.
Google it. You will find thousands of bodies. Google it. You will find thousands of bodies. Use your
Okay,
own
sir.
wit and will. I never indulge in spoon feeding. Dr. Raghu knows that.
Got it, sir. Got it, sir. Got it, sir.
Yep. I'm having a workshop in the end of July on informed consent for full week. Almost 8 to 9 to 10 hours. It will be there. End of July or beginning of August. It will be there. So again, a full thing with all the templates, with all the consent forms. So I'll inform in my WhatsApp groups. So wherever, if I told you the groups, if you want to be added over there. Dr. Dilip, I mentioned 3 years. 3 years you have to preserve your documentation. So any more queries?
Sir, Narayan, sir.
Sorry?
We asked, sir.
Sorry?
To our secretary, sir.
Okay.
Narayan, sir, is it audible? Sir, Narayan, sir, do you have any questions, sir?
Hi. Hello. Is it
Yes,
audible
sir.
now?
Yeah.
Sir, it's very clear almost. You answered almost every question with so much of enthusiasm for the past 1 or 2 hours. It's very, very hard to see such an energetic person nowadays. Okay, thank you very much. And and our president has almost made you to answer each and every question in a very interesting way.
No, I'm always there for all queries. I never rush the queries.
Yeah, and Dr. Raghu Ganesh was very much pointing towards you about your skill and your way of presentation, everything. And thanks for him also. And I thank everyone for listening and your enthusiastic approach. And we are still looking for a lot of queries also from, and we can forward to you so that you can answer them also.
Yeah, sure. I hope I justified Dr. Raghu's confidence in me.
Sir,
Very
definitely,
much, sir.
sir.
Very much,
Definitely.
sir.
Definitely.
Yeah, how
Usually
much ever
when
time
we
it
have
may
some
take, he leaves.
expectations.
Excuse me. How much ever he takes, he leaves no questions unanswered.
That's
He'll answer
great,
all the questions and he finishes the any session, sir. It's a one in all guru, sir. Finance, practice management. He does everything. He's a great mentor I have got in my lifetime. I should be very thankful to him.
Thank you.
Okay, so sir, please explain that indemnity insurance also for one session actually.
I recently took up it in 2 sessions. That video will be out on 16th of July. You can check out my YouTube channel. That is the reason I gave you the YouTube channel link. You can get subscribed to the channel. You'll be notified of all the videos. There are a lot of videos coming by the end of the month. 30th of June, you'll be getting 15 videos in that day, each one every hour on mutual fund. That is a series I'll be doing that day. It's my dad's 2nd death anniversary, so I'll be paying a tribute to him by this. So from 7 a.m. to 9 p.m. you'll get 15 videos every 1 hour. So again, minimum one webinar, minimum one video is there going to be every day till August. I have lined them up. So again, a lockdown thing, which I have utilized the time in both the lockdowns, 2020 and 2021. So not wasted time in any way. So now we are almost back to full practice in Punjab. So the webinars would decrease in nature, but yes, even if they decrease in number, they're already lined up till August. So I'll keep on doing short videos as such, but yes, the webinars will reduce after 30th June.
Dr. Rimo sir has raised his hand. Can I unmute him, sir?
Yeah, sure. Okay, I didn't change the setting, I guess. I'm sorry. Okay, you can unmute yourself and ask. No problem.
Doctor, that was a wonderful session. I would
Thank
like to appreciate you for the wonderful concern. That was a very good concern to inform. In fact, we've been doing this concern thing for the past more than 8 years since our clinic is an NABH accredited clinic.
Great.
So I would like to just bring a small point to you that there are people going to the Supreme Court against the dentist, and there are people going to the consumer court. Okay, so could you just make a few points on highlighting on that? What are the difference in between these two and the body of counsel, if the which could support the dentist?
The only thing is, if it is a civil case, if it is pertaining to a damages only, where there is no negligence involved, if it is a civil suit, then it goes to consumer court. Again, the levels are district court, state level, and the national level. Even the district range has been now increased up to 2 crores, I guess. Earlier it was around 10 to 50 lakhs or so. Even the local or the district court has a much range now. So if it is a civil case, it goes to the consumer court. If it is a criminal case where the gross negligence is involved, where they're kind of say damage, they always say negligence, we always say damage in mind, body, and reputation. So whenever the damage has occurred in these 3 dimensions, then it goes to the criminal court, or in the criminal sections of IPC are applicable. IPC 326, 336, 337, all these sections are applicable. There's which usually translate to injury of the tooth or the grievous hurt or a grievous hurt in those cases where you have damaged beyond the comprehension. So in those cases where negligence is involved, they are criminal, they go to the normal courts. Obviously, directly no case goes to the Supreme Court. They have to follow that channel of the JMIC, the district court, and then the High Court, and then the Supreme Court. But the CPA, again, 3 jurisdictions, primarily starting with the district one only, based upon the pricing part. So I hope I answer your question.
Yes, doctor. Yes, doctor.
Anything else, sir? Rama, sir?
So then there is also most of the common thing what most of the dentists they face is regarding the root canal failures. I suppose. Okay, that's where the perforation takes place, extent of the root canal, breakage of the file takes place at the apex region of the tooth, sometimes perforation extending beyond the apex of the tooth. These are the most common failures most of the dentists they feature and they highlight and see in that. So in these cases, if suppose a patient sues a dentist, and because recently also, not recently, like few years back also, I just read in a newspaper stating there was a little bit of perforation and the patient was not much satisfied with the dentist, and they filed against the dentist almost 50,000 to 1 lakh rupees, where the patient pays the dentist only somewhere around per tooth around 5,000 to 10,000 maximum, about 25,000 rupees. But they had filed against the dentist about 50,000 to 1 lakh, stating that you have literally caused a very bad injury to my tooth, which is a major part of my organ, they say.
The thing is that always these problems crop up when we don't mention the side effects of the treatment. I mentioned it very clearly in the presentation itself when these are mentioned as a part of the therapeutic hazards. These are the side effects of the treatment. If we have mentioned that verbally, got a signature as a consent from the patient knows that these are a possibility. Then if it happens, actually, God forbid it should happen, but if it happens, then we need to do or follow the principle of veracity or truth telling. We need to inform the patient, and in such cases, we need to take the services of a specialist if we ourselves are not competent enough to handle that. So if we actually jump and bypass that thing, and the patient gets to know from a third party that this is a situation because of this you are suffering, then the patient automatically joins the missing links and goes to the court. And the filing is advised by the lawyers only, number one. Number two, they always equate a tooth to a body organ. If the patient has had a tooth loss, then it is considered what benefits, the potential benefits the patient could have drawn from that tooth. So the damages are in accordance to. Then the biggest damage they claim is loss of mental peace. 90% of the claims are for loss of mental peace, as if the patient is living his life in a spiritual mode. And yes, only the dentist disturbed the spiritual mode and turned it into a situation where the patient lost all his mental peace because of that. So again, a lawyer guided thing only. So if you're following the particular sequence, even if you instrument separation is there, nobody can even touch you. Trust me, there is a colleague of mine who is in civil hospital, and he actually saved a colleague from 3 separated instruments in 3 canals of a molar. You can say the one breakage can happen because of a mistake. The second breakage may be another mistake. Maybe I was sleepy. But if you break 3 in 3, that is gross incompetence. But then again, always I say, you always be in good terms with your neighboring dentist also. You never know, he might be sitting in that independent medical or the dental board and giving an opinion against you. And just a couple of nights before, I was talking to that friend, the same friend I'm mentioning. He said, I have this big pile of letters received only today, directed to PMO, directed to Supreme Court, directed to CMO, directed to health CC, to health surgeon. It takes only an email directed to DCI, and said, and I have been told to initiate an inquiry. So I let these, luckily we are in COVID times, so I'm letting these die their own natural death. The time passes and the patient forgets the complaints. If they are marked again, then only I can't call a colleague to say that I've received a complaint against you. Most of the complaints are for dissatisfaction, but dissatisfaction is no reason to actually claim for negligence or claim for a refund. If you're not satisfied, does not mean that the treatment instituted or the treatment given was not good. So that is the thing. The compensation advised is by the lawyers, and that is offered by the judge in considering the equating the to a body organ. But yes, if you have not followed a proper protocol of informing, then taking a written consent, and then if it happens, indulging in veracity or truth telling to the patient, and lastly taking the services of a specialist or instituting the first aid, if I can say in that sense, then you are guilty. If you have followed that sequence and still the patient chooses to go to court against you, then you will not be harmed in that case. That is for sure. So don't worry about that part. I hope I answered your question.
Yeah. Is audio recording a good consent form during the patient dentist conversation?
You can take people do have CCTV cameras. They have CCTV cameras with voice also these days. You can do that, but a simple paper consent is valid enough with signatures. You can take a thumb impression, you can take a video consent, you can take a CCTV, you can do a CCTV with audio. Everything is valid. But if the basic is valid, why do I need to graduate to a further level? Why do I have to indulge in such a situation that I'm treating such risky patients? That is where, when I talk with the patient first, I understand, I know about it. Yes, this is not a good case to be started. So learn to say a no. Don't start the case. You have an upper hand at the start of the treatment. We are not supposed to treat everyone who walks through our door. We can still refuse all the patients. It is our personal choice. It is our rule. It is our clinic. Our rules will apply in our practice.
Thank you, doctor. Thank you.
Thank you, sir. Raman sir, thank you, sir.
Thank you.
Sir, our Tamil Nadu State President-elect has his words of appreciation for you, sir, now. Live, the voice alone, sir. Sir,
Sure.
Umashankar, sir, you can proceed, sir.
Good evening, everyone. And we had a wonderful session today. Really great to have Dr. Bhagdeep Singh. Really astonished with your academic qualifications. And I don't know how you find time to do all those things. Really, we wasted our life, I think so, for several years. At least I had an opportunity to hear your lecture, and sure will follow your YouTube channels. And also very proud of Tiruvallur branch. Already they have branch level consent form. They are having it. Just I came to know through this time of webinar, and really need of the hard topic, because lot of even last week IMA protested that violence against doctors throughout the national level. So everywhere it happens. And also we have a conscience that we explain the patient thoroughly about the treatment modalities. Otherwise, without the consent form also, we may also sometimes we may also take advantage. So it's both the win-win situation for both the patient and the doctor. And you are explained very patiently till 9:30. Very happy to have you for this webinar, and on behalf of Tiruvallur branch and IDA Tamil Nadu State, I thank you. Thanks a lot for sparing your valuable time. Thank you so much.
Thank you, sir. Thank you so much. Really a
you,
pleasure
sir.
being here in the branch.
So the best takeaway message for me, at least for me, today is what you said at last. The thing is, we are not supposed to provide treatment to every patient who walks into our clinic, actually.
Absolutely.
Super, sir.
Absolutely.
The best takeaway message for me, actually. Raghu, anything else?
You're muted.
Raghu,
Raghu.
unmute, Raghu.
I would like to hand over the certificate, sir, as a token of appreciation from our side, sir. Thank you very much, sir. That was a wonderful session. As usual, you rocked, sir, and you had been giving us lot of knowledge. And thank you very much, sir, for all that you are doing to us. Thank you.
I would request you to request your branch members who have attended to post the feedback to this session in your WhatsApp group, and you please forward me the same.
We'll
Yes,
do,
sir.
sir. We'll do, sir.
Thank you.
Yes,
Thank
sir.
you so
Thank you
much.
very much, sir. Thank you very
Thank
much.
Raghu,
you.
sir.
certificates, Raghu. Raghu, guest of honor certificate and
Yes, sir. Not added here.
okay, speakers.
Can you see this?
Yes.
Yeah.
Done. Visible.
That was our Dr. Bhagdeep Singh Ahuja for us. Thank you very much, sir. And as a token of appreciation, please kindly accept it, sir, from our side.
Thank you. Thank you.
Thank you very much, sir. Thank you very much.
So Narayan, sir, vote of the
Thank you, Bhavdi sir, for your kind information, for your presentation, and wish you a lot, and we'll follow you in your YouTube videos also. Thank you.
Thank you. Thank you.
So thank you, sir. Thanks a lot for your session, sir. Thanks a lot for your time, actually. Thank you. Thanks a lot, sir.
Thank you. Thank you. Thank you.
Raghu, let's
We
close
end-
the meeting.
Yep.
Done, sir. Thank you.
Just I'll inform if you can, if you want to switch off the recording, sir, or
Okay.
I would request members about IDA membership, sir. I would explain them the benefit of that. Just a minute, sir. For a minute.
No problem. Go on.